This is Dr. John Kruse, and I'm going to be talking today about the DEA proposals regarding prescribing stimulant-controlled medications, and this is September of 2025. So as usual, I'll start with the take-home message. Telehealth prescribing rules were relaxed during the COVID health emergency that ended in May 2023. The DEA has made several proposals to change or alter those regulations regarding controlled substance prescribing, and several, including those for buprenorphine and some of the opioids, have gone into action, but they've punted and delayed several times, although it seems like December of 2025, they will make some definitive changes. Changes they have proposed would significantly restrict access to telehealth medication for some individuals, and particularly it would be those who are most vulnerable and who have the least resources that are most likely to be affected. Further evidence that I will include here today that telehealth does not worsen outcomes of treatment for those with ADHD in any meaningful way. So these regulations seem to provide no benefit and will be almost certainly killing people, because ADHD is a potentially lethal condition. So historically, the government for decades has been pushing to increase the number of people who use telehealth, particularly in rural areas where there were fewer providers, not just mental health, but physical health. And they were sort of astonished that year after year, less than 1% of medical interactions occurred via telehealth. Then the COVID pandemic occurred in spring of 2020, hitting the US. There was an immediate relaxation of many of these telehealth regulations almost overnight. For mental health care, less than 1% of visits by telehealth jumped to more than half of visits for mental health in the months after restrictions were loosened were telehealth visits. Since then, that's settled down somewhere closer to 40%. It's still a higher percentage in most other medical fields, but it's a substantial one. I'm not pretending that relaxing the rules was the only reason for that huge surge. Now, some of it certainly was. Both providers and patients were reluctant to put themselves in a contagious environment, so that contributed to adopting telehealth and reimbursement policies. So for years, there was penalties or reductions. You got paid less if you did the same services by telehealth. That was changed during COVID. Research that was done pre-COVID showed that evaluations for ADHD could be done effectively during a telehealth visit, and also the quality of care and patient satisfaction with care were as high with telehealth visits as they were with traditional inpatient services, in-person services. Other research on who uses telehealth in the last decade have shown it tends to be people of less financial resources, so people who can't afford to take time off, overrepresented among people who have multiple mental health problems, partly because, again, mental health problems pose challenges to mobility, whether it's anxiety, whether it's depression, whether it's disorganization and schizophrenia or ADHD, whether it's stigma about going to a mental health clinic. All those are lessened via telehealth. And also specifically, a higher proportion of those with a substance abuse history are more likely, partly because of overlapping financial and mental health problem reasons, to rely on telehealth. So there's also good evidence that the more barriers you put up to access to telehealth, the fewer people are going to use it, and that cutting access to telehealth is going to consequently hurt those who are most vulnerable, most in need of services, and who have the least ability to make it in-person treatment. And again, because ADHD is a condition that kills people primarily through suicides and accidents, this is not a trivial situation. This means less care, and particularly less stimulant medication in this population, does equate to more dead people. On the other side of this equation was the media gave huge amounts of attention to a massive surge in ADHD diagnoses via telehealth during COVID, and prescription for stimulant medications did increase. What's important is looking at what those baseline numbers were and when they cite what the percentages were. So in absolute terms, still pretty clear we're undertreating ADHD in this country, and that fewer people are being treated than we know have ADHD. fewer people are diagnosed, and even a smaller percentage are treated with stimulant medications. Furthermore, most of the increase during COVID was not among children. Those rates have been increasing the decade before. Rates in children were fairly stable. The big change was diagnoses among women, diagnoses among young adults, diagnoses among other minoritized individuals. The best explanation for this is that these are groups that ADHD had been underdiagnosed in up until that time, and or those individuals were able to mask, cover up, or cope with things until the crises of the pandemic made work in childcare and other things more difficult. A factor that's changed over the last decade is actually the number of prescriptions for stimulants by psychiatrists have been fairly stable across the last decade. For pediatricians, they've been fairly stable. Primary care providers, family practice doctors, there was some increase for a few years. That's been pretty stable for the last 5 or 6. But there's been a meteoric rise in the number of nurse practitioners prescribing stimulant medications. So it was a tiny fraction 10 years ago of the total prescriptions, and now they are the single biggest prescribers of controlled substance stimulants for ADHD. Now, that's not necessarily a good thing or a bad thing. In general, those practitioners do have less training than medical doctors. There are certainly many excellent, thoughtful, careful diagnosticians among nurse practitioners, but on average, again, they have less experience, they have less education, and they can be paid a lot less. So one is that a disproportionate number of nurse practitioners are employed by the massive telehealth centers that sprang up during the COVID years, many of them catering specifically to ADHD, many of them boasting that you could get a ADHD diagnosis in just a few minutes and get medications for ADHD in just a few moments. Another statistic compiled by the DEA is that there's been a remarkable uniformity in the initial dosing of stimulants by these nurse practitioners at telehealth centers, indicating that there might be some cookie cutter just doing the same thing and not tailoring individual prescriptions to the individual patients. But there are mechanisms for shutting down bad faith telehealth providers. A big company called Cerebral, another company called Dun Global, have been fined millions of dollars. They've been shut down because the DEA and other government agencies had enough evidence that they were pushing medications, they were doing unthorough evaluations. So it's not clear, given that we already have the tools to shut down centers that are doing a bad job, why the DEA needs more restrictions. Part of it, again, is their concern. So 2 things. The DEA's mandate is conflicting. One is that they are in charge in the U.S. of making sure there's an adequate supply of appropriate controlled medications for prescribing purposes. And their second part of their mandate is to prevent the manufacture, importation, and distribution of illicit substances of abuse in this country. And throughout their history, much more of their manpower, resources, institutional focus has been on law enforcement, intercepting drugs, rather than on the other half of their mission. Valid reasons for them to be concerned. Part of it is they were flat-footed and weren't effective in dealing with the opioid crisis at earlier stages when they might have. So historically, in the U.S., there have been trends where, following an opioid epidemic, there have been stimulant epidemics. Not an extensive pattern, but there's some backing for that historically. 2 is that the opioid epidemic could be described as starting out as a medical condition. So concern about pain in the 1990s led to doctors spending much more attention on pain, treating pain more seriously. And this led to an expansion in different opioid medications, so a massive increase in the number of options. That wave preceded illicit heroin epidemic, was the second part of the opiate epidemic. So the DEA sees a strong parallel with ADHD, which they, at least in some of their speakings, delegitimize, as they are delegitimizing the treatment of pain. Do note that there was a fairly substantial increase in the number of options are for treating ADHD. The biggest component now of the opioid epidemic is people are taking opioids concomitantly at the same time as they're taking a stimulant. So there's good reasons for the DEA to be concerned, but it's not at all clear how their proposals will actually help reduce this problem. So jumping into what the proposals suggest, and these are not all of the proposals. One is that any new person starting for the first time on a controlled substance would require an initial in-person visit before they're given any Schedule 2 through 5 medication. Schedule 1 are drugs that are considered so dangerous, so prone to abuse, that have no medical use. So they include mescaline, peyote, LSD, psilocybin. Schedule 2 are drugs with substantial risk for abuse, like amphetamines and methylphenidate. 3, 4, 5 are less restricted, but still pose some danger, with the benzodiazepines for sleep being in that category. And most medications are not controlled in this. Even if they require a prescription, they aren't on any schedule. So, and it may be modified. It's just a proposal, is that any person getting any Schedule 2 through 5 prescription has to have an initial visit in person with the provider. Second one is that they would set up a new system. So there would be a new additional license for any prescriber who wants to write any 3, 4, 5 scheduled controlled prescription, another additional, more restrictive license for any provider who wants to write any Schedule 2 substances. The fees for those licenses would be, I think, pegged at $888, but you would need one potentially for each state. At least that was the initial proposal. Almost certainly they would require special training or courses, which would probably add hundreds of dollars to the cost of this. Extensive new regulations for the registration of any telehealth medication platform, and that the DEA would get to decide whether that telehealth practice was actually essential or not. Two more regulations that have been proposed is it would completely curtail any across-state border controlled substance prescribing. And one of the most bizarre is that every prescriber would be limited to less than half of their controlled substance prescriptions could be done via telehealth. Like I am completely working remotely now. I'm not part of any big telehealth medicine company conglomerate or corporation. It's just me. But this rule as proposed would say half of my controlled substance prescriptions would have to be in person, not remotely. Two studies that have been just published that I'm going to cite. So one was a study looking at almost 64,000 individuals through federally collected surveys, data, and they broke people into two groups. A little less than half the group, 43%, had at least one visit through telehealth. The other, slightly bigger group, all of their visits were completely in person, so nothing was telehealth. Now, this does not track or break down how many visits the person had through telehealth. It's just one or more. It doesn't separate out video from phone, from even texting. What they looked at was the rates of misuse of stimulants, misuse of opioids, and misuse of benzodiazepines, anti-anxiety medication like Valium, Klonopin, Xanax in the year after their entry into this study. And if you look at the initial raw data, it looks like substance abuse was higher among people who were in the telehealth, any telehealth, versus people who were only live. But they went back and corrected because, as I said earlier, those individuals who were getting any telehealth visit had substantially higher rates of pre-existing substance abuse or prior history of substance use issues. They had higher rates of mental health disorders. They had higher rates of poverty and socioeconomic stress. And if you corrected for those, there was absolutely no increased rate in abuse of any of these three categories of drugs for people who had telehealth visits. So again, it's refuting the DEA's rationale that somehow telehealth visits will lead to greater rates of substance abuse. That was not found once you corrected for prior history of substance abuse problems. So a smaller study looking at a different population, so almost 8,000 people age 12 or older, so the other group was only adults. This is a Mass General medical record study. Average follow-up was 3.5 years. And what they looked at was people who had telehealth-only visits versus any in-person visit at all. They looked at rates of substance abuse problems or stimulant use disorder. Again, these are people all with ADHD, all who are being treated for their ADHD, and there was no difference in terms of developing any substance abuse problems or any stimulant use problems specifically if you looked at telehealth only population versus any in-person evaluation. Then they broke down the data in a different way, and instead of looking at any treatment or any interaction with the clinic, they looked at what happened with that initial visit. Was that initial visit for a stimulant prescription a telehealth visit or an in-person visit? There was no change in substance abuse. Rates of substance abuse disorders, rates were quite low, despite 3.5 years in study, equal in the telehealth group versus those who had an initial meeting in person when they got their first stimulant prescription. On the other hand, specific problems with stimulant use problem were 6 times higher in the group that only had a telehealth visit compared to, so again, this is breaking out stimulant use disorder from substance use disorder. Now you would look and say, oh my God, 6 times higher. This is catastrophic. If you look at the numbers, what they said was 99.6% of people who had a telehealth visit on their initial visit were not abusing their stimulant within the 3.5 years of follow-up. In contrast, if you had an in-person visit, your rate of not abusing stimulants in 3.5 years was 99.95%. That was a statistically significant difference, but I would agree with the authors who would maintain this does not appear to be a clinically meaningful difference. You're not going to treat one group because less than a 0.4% chance of abusing versus less than a 0.05%. It's such a small risk in either group, so this is not a clinically meaningful difference. And this study also confirmed that the group who was in the telehealth only had higher socioeconomic stressors, had poorer mental health. So again, if you are making it harder to treat people via telehealth, you will be preferentially harming the people who use it the most right now, which are the ones who are most debilitated to begin with. Do I have a vested interest in this? Yes. So if all these proposals came to pass, would I be willing to pay for the training and a few $1,000s to get licensure to prescribe? Yeah, I'd probably be willing to do that. Currently I have both the medical license in California and Hawaii. I have DEA licenses in both states. I'm not taking any new patients, so I would have patients who are grandfathered into some of the clauses. All the patients I'm working with, I've seen already and I've seen in person. But the clause about half my patients would have to be seen in person, that one I don't see any way around as written. And again, it's not at all clear why that is reasonable. And of the colleagues I know, many colleagues gave up their offices, many psychiatrists during COVID. Many of them switched to a completely telehealth mode. Some are in a partial mode, but many are not even in a position to see half their patients in person anymore. Whether these come to pass at the end of this year, we don't know. What's alarming is that right now these are coming to pass under an administration that both actively disparages and devalues research and science and expert opinion and research, and particularly if those disagree with those in power. Secondly, this is an administration that expressed extreme disdain for those suffering collateral damage, whether it's people swept up inadvertently in ICE deportations or otherwise fall victim of massive overreach on their part. They are very much into blaming the victim. They shouldn't have been in the way. It's their fault. So I don't think on either science or sympathy we're likely to appeal and get much help in changing these rules. On the other hand, these are all still politicians and they are potentially responsive to massive outcries. So why the DEA rules may have a negative impact on you, and letting your congressman and the DEA know that may be of help. So stay healthy, stay happy in this not particularly sane world.